My patient XYZ, 35-year-old female, housewife by occupation, resident of Hapur, UP. She is illiterate and right-handed person, and informant being her husband and herself seems reliable. She presented with our emergency with chief complaints of right upper limb weakness since 2 years, nasal intonation of speech since 1.5 years, nasal regurgitation of food since 1.5 years, and left upper limb weakness in 6 months. History of presenting image. Patient was apparently normal 2 years back when she noticed weakness in the right upper limb, which was insidious in onset and gradually progressive in nature. Patient initially noticed weakness while combing her hair, lifting her arm above the head while taking bath. That difficulty was there throughout her range of motion. Over a period of next 4 to 5 months, patient also noticed difficulty in breaking chapatis, mixing food, buttoning and unbuttoning of her clothes in the right upper limb. She was also gives history of difficulty in holding a glass of water and opening a cap of water in her right arm. Over next to 4 5 months, patient had developed severe weakness such that she had to take the help of other limb, that is left lower upper limb, to move is her right upper limb. Simultaneously, patient and her husband also noticed involuntary twitching movement in the right upper limb. Patient husband also noticed thinning of her hand and upper part of her arm. However, patient denies any pain in the limb during this course. There was no history of painful muscle contraction or any abnormal movements at the joint level that she has noticed. Patient husband also noticed change in the quality of her voice in the form of nasal intonation since 1.5 years, which was insidious in onset and gradually progressive. Over next 6 months, it has progressed such that her words are not non-comprehensible. However, patient is able to understand the word and respond back to the commands. There is also a history of nasal regurgitation of the food particles since 1.5 years, which was insidious in onset and gradually progressive. She was having the nasal regurgitation for both liquid and solid food. However, there was no history of cough after eating or while eating, or history suggestive of any aspiration. Patient also gives the history of difficulty in mixing food inside her mouth while eating and swallowing since 1 year. Patient have been taking for the above complaints. Patient has to take the food along with the water, and she is consuming predominantly liquid food to avoid the difficulty in swallowing since 1.5 years. There is a history of difficulty in protrusion of tongue. However, there was no difficulty in chewing food or opening the mouth. There is no history of drooling of saliva or water from the angle of the mouth. There is also a history of weakness in the left upper limb since 8 months. Patient noticed difficulty in combing her hair and brushing the teeth and overhead abduction of her arm, which was insidious in onset and gradually progressive. There is no history of difficulty in buttoning and unbuttoning of her clothes in the left limb. There is also a history of twitching movements she noticed in the upper part of her left limb since 4 months. That weakness is not associated with the pain at any point, or it is not associated with the stiffness. There is a history of difficulty in uh, uh, elevating the head from supine position since 8 months. Patient also noticed thinning of her neck since 8 months. There is a history of difficulty of rolling over in the bed since 4 months. She was having the difficulty in the rolling over more to the left side more than the right side. There is no history of difficulty in getting up from the squatting position. There is no history of putting slippers, holding, gripping, or removing the slippers. There was no history of any abnormal twitching movements in the lower limb. There was no history suggestive of cramps or painful muscle contraction or any enlargement of the muscle in the lower limb. There is no history of falls or swaying while walking or difficulty in walking in the dark. There is no history of thinning of lower limb. There is no history of the tingling, painful, or burning sensation over the upper limb or lower limb. There was no history of difficulty in appreciating the cold or warm water while taking bath. She could able to perceive the vibration of her mobile phone. There is no history suggestive of bowel and bladder involvement. There is no history of decreased vision or smell. There is no history of diplopia or difficulty in looking up or down. There is no history of loss of facial sensation or taste sensation. There is no history of difficulty in hearing, or there is no history suggestive of any cognitive impairment or emotional lability. There is no history of giddiness or vertigo. There was no history of tremor or any abnormal movements. There was no history of difficulty in breathing. There was no history of seizures or loss of consciousness or headache that she was noticed. There was no history of exposure to any drugs, toxins, or any heavy metals. There was no history of significant weight loss. Past history.
We can
Patient
come back to
will-
the presenting complaints. I think we
Yes,
can
sir.
discuss it.
Yes, sir.
Yeah, go to the next slide. Okay, so what's your inference? What sort of disease are we dealing with?
Sir, it is a chronic disease which is
It's a
involving,
chronic disease.
yes, sir,
Okay,
which is involving the upper limb predominantly, that too asymmetrical.
asymmetric in onset. Okay,
Asymmetrical and gradually progressive,
okay,
and it associated with it is also associated with the lower cranial nerve involvement.
okay. So it's
Uh,
associated with lower cranial nerve involvement. Okay,
yes, sir.
asymmetrical in onset. Which part
Yes, sir,
of the
gradually
nervous system is which part of the nervous system is predominantly involved?
Sir, motor part of the nervous
Okay, so
system
there
is
is a motor
predominantly.
weakness that the patient is complaining of.
Yes, sir.
So in your first complaint, you said that there is right upper limb insidious onset of weakness.
Yes, sir.
Which part of the arm is predominantly involved in this patient?
Sir, initially she was noticed a proximal muscle weakness in the form of combing, difficulty in combing her hair, lifting the arm above the head. And next 5 4 months, she also noticed difficulty in the distal muscles in the form of breaking chapatis, mixing food, buttoning or unbuttoning.
What is the relevance of this?
Sir, based on the which muscle involved and progression of the disease, certain disease follows the like myopathy
Okay,
and all.
like
Sir, if you are dealing with the myopathy, they predominantly involve the proximal muscles initially and certain groups of myopathy.
okay,
And if we're dealing with any degenerative disease or any peripheral neuropathy, motor neuropathy, length graded, that in that case, distal muscles will be involved predominantly.
okay. So in your patient, it was proximal first and then went to distal.
Distal. Yes, sir.
So basically, you are saying that it is possibly a muscle disease.
Yes, sir.
What are the other
Muscle.
diseases which comes proximal?
Sir, proximal muscle weakness, it can be like neuropathy, peripheral neuropathies like AIDP and CIDP. Those can also involve the proximal weakness or any neuromuscular junction disorder like
Neuromuscular junction disease, correct?
myasthenia gravis.
Neuromuscular junction disease. That was you are not mentioned in your history to suggest neuromuscular disease. What is that history you would have already
Sir,
mentioned?
waxing and waning, any fluctuation, any diurnal variation of the symptoms.
So that was, I mean, though it's not so common in your patient, the history is totally different.
Yes, sir.
But still, you have to mention it when it is a pure motor sort of weakness that is there. You should mention history suggestive of waxing and waning. Okay. So you said the neuromuscular junction disease, muscle disease, and your demyelinating neuropathies are the ones which come proximally. That's the one which would come proximally.
Yes, sir.
Okay. Which group of muscles are involved in this patient first?
Sir, here, sir, like proximal muscles, like initially, sir, infraspinatus deltoid and trapezius are involved in initially, and later the small muscles of the hands also involved.
Okay, you said combing of hair. Combing of hair is only proximal muscles?
No, sir. Flexors of the forearms also involved in the combing.
Yes, there is distal also. No? Combing of hair, there is distal part is also involved. It's only not proximal.
Yes,
so here the onset was mixed. Look like because you said combing of hair first.
Yes, sir.
And then you said lifting of arm above the head and all.
Yes,
so combing of hair is a mix there. It's not only proximal.
Yes,
it has the flexors of the hand that is also getting involved and possibly some small muscles of the hand also getting involved.
Yes,
so when you say that combing of hair, you should be a little careful to say because here your history, it looks like you have written in a form that it went from proximal to distal. But then that combing of hair is a little mixture there.
Okay, sir.
Dr. Sharath, any comments on that part?
My muscle disease, like we like to consider muscle disease or anything against muscle disease or anything supporting muscle disease. One is pure motor aspect supporting the muscle disease at this point.
I think Dr. Sharath, your audio is a little low.
Yes, sir. Hello, sir.
Yeah. Now it's better.
Yeah. This muscle disease, as it is a pure motor syndrome, we can consider muscle disease. So, can you tell like what makes it odd for a muscle disease in this beginning scenario?
Sir, here in sir, asymmetrical involvement and proximal muscle involvement.
Yeah, symmetric involvement which will make the muscle disease and even the neuromuscular junctions also
Yes, sir.
unlikely.
Yes, sir.
Even asymmetric forms of muscle disease are also known.
Yes, sir.
Like facioscapular humeral dystrophy.
Yes, sir. Yes, sir.
And the other thing is that same as sir told, like combing of the hairs, like better to mention whether it was gripping the comb, difficulty in gripping the comb or lifting the upper limb above the head level. That was the only thing.
Okay, sir.
Yeah, a little more detail possibly. When you say that, you'll have to say that a little more detailedly what is combing of hair and how. Okay. So the basic thing that we are talking here is it's an asymmetric concept, isn't it?
Yes, sir.
So asymmetric concept of the disease that we are talking about, which is involving the motor system predominantly. Yes. What was the progression?
Sir, it's a gradually progressive, sir.
It was a gradually progressive over a period of
since 2 years she is having this difficulty.
Yeah. So within a year it became to the other side also it went on, isn't it?
Yes, sir.
Okay. Fine, you can go to the next slide.
Sir, over the next 4 to 5 months, the patient also developed severe weakness.
Raghu, your voice is very.
Yes, sir. Yes, sir. Yes, sir. Sir, over next 4 to 5 months, sir, patient had severe weakness in the left upper limb, such that she has to take the help of her left upper limb to move her right upper limb, sir. Simultaneously, hello.
Yeah, yeah.
Yes, sir. Simultaneously, patient husband and patient noticed involuntary twitching movements in the right upper part of the right arm, sir.
They volunteered this information, or you asked?
Yes, sir. Yes, sir. Yes, sir. They gave the history of they noticed this.
Yeah, sometimes they may not volunteer, but maybe on examination you may find it. You will have to ask for it. So what is that movement you're talking about?
Sir, most likely fasciculation only, sir.
Okay. Why do you say it's fasciculation? Why is it not a tremor or a myoclonus?
Sir, tremor usually rhythmic movement you see across the joint, sir.
Okay, so what's the description that this patient told you about these movements? Where was the movements?
Sir, upper part
right arm, na? Right arm is a full arm.
Yes, sir. Upper part of the right arm, sir, like in the deltoid region, they told, sir.
Okay, so you say that specifically in the particular muscles they noticed.
Okay, sir.
How does a fasciculation differ from other movement disorders? Why is this fasciculation not classified under that?
Sir, fasciculation usually one group of muscle fibers will be involved, sir. So it won't cause any movements across the joint.
Okay, so there is no gross movements, it's only visible.
Yes, sir.
Visible under the skin that is there. Okay. Yes, can you explain? Can you tell us what is the mechanism of fasciculation?
Sir, fasciculation is basically because of the denervation. So one group of muscle which are supplied by the one motor unit, because of the hepatic conduction in the degenerative nerve, there will be movement in the group of muscle which are supplied by the one motor unit, sir. That degenerative nerve motor unit.
There is a denervation. That's the word you said, denervation.
Yes, denervation.
Okay. So when do you say fasciculation is significant?
Sir, when it is associated with the atrophy of the muscle, it is significant, sir.
Okay.
And
just one muscle group if it is present?
Sir, if it's atrophic muscle, it is significant only, sir.
But atrophic muscle, it is significant.
Okay. Yes, sir. And
otherwise?
That frequency, number of times patient has noticed.
That could be course fine. That's okay. That's subjective.
Yes, sir.
Any other points to say fasciculation is significant? You said in atrophic muscle,
yes, sir. Yes, sir.
It's significant.
Yes, sir. I'm not sure, sir. Like increased frequency of the fasciculation, or I'm not sure, sir.
Okay, if in a motor neuron disease, what are the regions we divide? How many regions of the body we divide?
Cervical, thoracic, lumbar, and lumbosacral.
Yeah, so cervical, thoracic, lumbar. So if it is there in more more than one
okay, sir.
regions possibly associated with atrophic.
Yes,
okay,
sir.
is also significant.
Yes, sir.
Dr. Sharath?
Yeah. Raghu,
Yes, sir.
yeah, would you like to consider radicular involvement as it is like pure motor radical or pure motor root can also be involving and asymmetrical, and whereas root involvement can be asymmetrical as we already know.
Yes, sir.
So anything against radical here or a root involvement here?
Sir, no sensory involvement is there, sir, not there, sir. And
Yeah, that cannot be involved. Okay,
sir?
one sensory and pure motor root involvement can also be there. Actually, both motor and sensory root will join to form a compliant radical, and it will exit the intervertebral foramen. So
Okay, sir.
pure root involvement can also be possible.
Sir,
Okay.
root involvement, basically that particular nerve, whichever the muscle supplied by the particular nerve will be, particular group of muscle which are supplied by that radical will be weak, sir. Here it's only that muscle fibers, fasciculation is hard against that radiculopathy.
Yeah, here it is a significant thinning and the fasciculation which you have mentioned, and another one is the pain.
Yes, sir.
Pain must be definitely mentioned in this case because uh, the neck pain especially should be definitely mentioned.
Yes, sir.
So the most treatable entity which we will be considering in this case of like this scenario.
Yes, sir.
So, that Lermit symptoms and the
Yes,
neck
sir.
pain.
Yes,
So
sir.
it would be better if you add those in the history also.
Okay, sir.
Okay, so muzzle against is again asymmetrical pattern, and
Yes, sir.
also the proximal okay, but distal involvement is also there. And
Yes, sir.
points against root involvement are the absence of the pain, neck pain, or no Lermit symptoms in case of
Okay.
if there is any compression to the cord.
Yes, sir.
Okay.
Okay,
And
sir.
peripheral nerve.
Sir, peripheral nerve, that's what, sir. One is that sensory involvement is not there.
Yeah.
And one more that usually pattern of asymmetrical and muscle involvement.
Symmetrical is there, but asymmetrical can be there. If
Yes,
you
sir.
take in case of lead poisoning, you can have a
Motor,
asymmetrical
pure motor.
motor neuropathy, but that is usually a distal phenomenon.
Distal.
So ridge drop is most common entity, but
Yes, sir.
proximal thing is very unlikely.
Yes, sir.
So just even the pure it is, so till now whatever the history we have is a pure motor syndrome affecting the right upper limb.
Yes, sir. Yes, sir.
So based on this pure motor thing, so where would you like to put your localization? Muscle is unlikely because you told asymmetric.
Yes, sir.
So
And
nerve is unlikely because
neuromuscular junction is also unlikely, sir.
unlikely. Yeah.
Nerves also, it's unlikely, sir. Like motor anterior horn cells.
Okay,
It's
so
possible thing, sir.
so till now, like you have not mentioned any. We don't know whether it is a pure LMN or a
Yes, sir. Yes, sir.
regarding. So further, I think you will be covering. Okay, we
Yes,
will
sir.
go on then.
Yes, sir.
Yeah, proceed.
Sir, patient denies any pain in the limb during this course, and there was no history of painful muscle contraction or abnormal movements at the joint level that she has noticed. Sir, patient husband also noticed change in the quality of her voice in the form of nasal intonation since 1.5 years, sir, which was insidious in onset and gradually progressive. Over next 6 months, it has progressed such that our words are non-comprehensible to her husband, sir. However, patient is able to understand the words and respond back to the comments. There is a sir. Yes, sir.
So what is this phenomenon you are dealing with now?
Sir, sir, bulbar involvement.
Speech disturbances, basically.
Sir?
Speech, it's a speech disturbance. Okay.
Yes, sir. Yes, sir. Dysarthria, sir. Sir, this is speech disturbance, sir.
So it's not a language disturbance; it's a speech.
It's
disturbance.
a speech disturbance, sir.
So to defend that, you have mentioned like he is able to understand the words
and respond back to the comment.
So what kind of speech disturbance or what kind of dysarthria?
Sir, sir, actually, because of the nasal intonation, he is not able to tell which kind of speech it was. But definitely, there was no like spastic kind of voice was not there, sir.
So nasal
It's a
intonation, what
yes,
would
sir.
suggest to you?
Sir, flaccid type of dysarthria only.
Yeah, nasal intonation. And another thing which is supporting here, suggesting a flaccid kind of thing.
Sir, nasal regurgitation.
Okay, so what would you expect in a? So it is basically a speech disturbance. Mainly you are thinking of a lower motor neuron, that is a flaccid dysarthria,
Yes,
which
sir.
is due to a bulbar involvement.
Yes, sir.
So why not it is a like upper motor neuron bulbar involvement or a pseudobulbar?
Sir, pseudobulbar, one thing is patient will be having, that can be associated with the emotional liability or cognitive impairment, sir. And
That's
one more
what
thing,
mentioned.
more than nasal regurgitation, they will be having oral regurgitation.
Yeah. So one more thing is the excessive choking. So
Yes, sir. Sir.
patient will have excessive choking in case
Choking.
of a pseudobulbar or a UMN lesion, whereas
Okay,
it
sir.
is regurgitation in case of an LMN lesion.
Yes, sir.
So that history of pseudobulbar effect should also be mentioned.
Yes, sir.
And what are types of dysarthria, or like what do you know regarding the types of dysarthria?
Yes, sir. Types of dysarthria. One is a flaccid type of dysarthria that we will see in LMN type of bulbar palsy. One more is spastic type of dysarthria that you see in pseudobulbar palsy, and one more is cerebellar dysarthria. We can see two types of dysarthria here. One is that expulsive speech staccato dysarthria, or one more is ataxic dysarthria. And hypokinetic dysarthria, hypotonic dysarthria in Parkinson disorder, basal ganglion involvement. Patient will be having tone of that speech is very monotonous and low. That voice that sound is low, sir. Monotonic speech will be there, sir.
And like how will the patient will tell to you, like
Yes, sir.
here in nasal intonation is suggesting a flaccid, but otherwise
Flaccid.
how will the how will you differentiate historically the spastic dysarthria and flaccid dysarthria? Here the points are nasal intonation, and
Yes, sir.
another point adding is nasal regurgitation, but
Yes, sir.
otherwise what other features you would expect?
Sir, like spastic dysarthria, patient gives the history of that hard potato voice, or he was patient tell that he has to stress more to produce the words.
Yeah, so the
Yes,
strainful
sir.
voice quality.
Yes, sir.
And in case of flaccid dysarthria, the mainly the depending upon the type of depending upon the muscle involved in the articulation, the
Yes, sir.
dysarthria will differ. If it is a seventh nerve palsy causing weakness of the orbicularis oris, then it
Yes,
will
sir.
be the labial
Labial
pronunciation that will
dysarthria,
be
sir.
affected. If it is
L
a
and
tongue,
B.
so depending upon the muscle involved, it can differ. So
Yes, sir.
whereas the spastic dysarthria is the syllables are completely running into each other,
Yes, sir.
and other coexisting features like pseudobulbar effect or choking episodes, these would
Yes,
add on to your support your spasticity.
yes, sir.
And what more you will ask a history. uh, Another few points has to be added in a
Sir,
patient with this
sir,
nasal.
dysarthria basically, which if patient is having difficulty in talking, we should ask about which particular words he is having difficulty, sir.
Yeah.
But here, patient is not able to make out what she is telling, so I couldn't get that history, sir. Actually.
Okay. So one more thing I would like to add to this is like patient is having nasal regurgitation and is having nasal intonation. So patients with this nasal regurgitation, they tend to usually avoid the meal.
Yes, sir.
They
Sir.
will keep on avoiding the meals, and gradually they lose their weight.
Yes, sir.
So which will again lead to further aggravation or the further worsening of the symptoms already the patient had. So
Okay.
history of loss of weight will also signify the extent of nasal regurgitation the patient is having. Whether
Okay,
if
sir.
the nasal regurgitation is very occasional, then there will not be no history of any loss of weight or,
Okay.
and also that any previous history of hospital admission for lower respiratory infections like pneumonia, which would
Sir.
add on to history of aspiration.
Okay, sir.
Would be, yeah.
Yes, sir. There is also, yes, sir. There is also a history of nasal regurgitation of food particles since 1.5 years, which was insidious and gradually progressive. Sir, nasal regurgitation was there for both liquid and solid food, sir. However, there was no history of cough while eating or history suggestive of aspiration, sir, like previous pneumonia or any hospital admission.
And one more thing, or another point, what you would like to add is the change in the voice force.
Yes, yes, sir.
So many patients we will see in either a stroke or in any kind of bulbar involvement.
Yes, sir.
They will be having nasal intonation and this nasal regurgitation, but force is unfortunately also seen, but not very common as the nasal intonation or nasal regurgitation.
Okay, sir.
So how would you support it?
Sir, like hoarseness of voice is there, patient.
Yeah, hoarseness, like all are related to 9th and 10th cranial.
Yes, sir. Yes, sir. Yes, sir.
Pharynx or nasopharynx.
Sir, vocal cord involvement causes hoarseness of voice.
Yeah, that's
sir.
really. So everything is a 9th and 10th complex.
Yes, sir. Yes, sir.
Larynx,
Yes,
nasopharynx,
sir.
or
Yes, sir.
epiglottis, everything is 9th and 10th complex.
Okay,
But
sir.
we see usually patients only with many of the patients will complain of nasal intonation and nasal regurgitation rather than hoarseness of voice.
Hoarseness of
Even
voice.
if it is lateral medullary syndrome or any other patient.
Yes, sir.
So any specific reason like why many of the patients are coming with nasal regurgitation and nasal intonation but not hoarseness? Hoarseness can also be there.
Yes, sir. Yes, sir. The recurrent laryngeal now nucleus. I don't. Yes, sir. Yes, sir.
Actually, in the nucleus,
Yes, sir.
there is a representation depending upon the nasopharynx, oropharynx, and the larynx from the
Yes, sir.
anterior to posterior in the vagal nerve nucleus.
Yes, sir.
So, if the anterior nucleus is the most common thing, which is anterior part of the nucleus is which is most commonly involved in either stroke or in any case of degenerative lesions, whereas the posterior part of the nucleus is generally relatively unaffected. So, many of the patients, as if you have a spinal nucleus of trigeminal nerve, which has a onion peel pattern representation anterior to posterior in the
Okay,
spinal
sir.
tract of the trigeminal nucleus. So, similarly, the similar segmentation is there for vagal nerve nucleus in the brainstem of the
Yes, sir.
anterior. Contemporary
Yes, sir.
area representing the land, because the question generally that may not fit or not in usual.
Okay, sir.
Yeah, you can proceed to the next slide.
Yes. Patient also gives the history of difficulty in mixing food inside her mouth and swallowing since 1 year. Patient has been taking food in order to avoid these symptoms. Patient is taking food along with the water, but since last 8 months, she is taking more only liquid food only, sir. And there is a history of difficulty in protrusion of tongue. There was no difficulty in chewing the food or opening the mouth. There was no history of drooling of saliva or water from the angle of the mouth.
Okay, here the patient is taking more liquid,
Yes, sir.
but you expect the vice versa generally in case
Yes, sir.
of
Yes,
urogenic
sir. Sir.
patient. So how do you support it?
Sir, she is not able to take the solid food, sir. Like she is not able to mix that food inside the mouth. So she was telling she used to take that dal or only fruit juice, liquid kind of food only, sir.
But that will cause more of
No more regurgitation.
actually the thing is many people.
Yeah.
Other thing is the effect of gravity.
Yes,
So
sir.
which could help in this patient, which could so that food easily passes. Whereas in case of a hard food or a solid diet, it
Yes,
takes
sir.
much more time. Whereas the liquid diet it will pass very soon. So they
Yes,
will sit straight and then they will take the liquid food. So that
okay.
due to gravity effect, and which makes them feel much more better.
Okay.
So that was the time. How did you ask for this protrusion of the tongue historically?
Uh, like, sir, I just directly asked, sir, like any difficulty in.
So that I think while cleaning the teeth in the morning, at that time you
Okay.
can ask the while the teeth is done, is there any difficulty?
Okay,
So
sir.
it is mainly the protrusion, not the protrusion of the tongue, but the manipulating of the food from one side of the oral cavity to other, and
Okay, sir.
the speech disturbances, which would, that will represent the weakness of the tongue.
Okay, sir.
And they also mentioned there is no issue of drooling of saliva and water from the angle of the mouth. So
Yes,
this,
sir.
you are highlighting the
Facial now,
facial.
orbicularis oris muscle involvement.
Particular stories. Okay, so in this history of drooling and facial deviation are usually expected when the weakness is very advanced,
Yes, sir.
very early stages of facial weakness. Then how would you ask for minimal facial weakness history?
Sir, when they're any asymmetrically while smiling,
Yeah, very good. One other thing.
other thing is like, uh, sir, accumulation of the food in the vestibule of the mouth.
Okay.
Or
Further, another few activities like drinking of water from the straw. And
okay, sir.
in case of male patients, if they are a smoker, they will have difficulty in puffing the smoke from
Okay.
cigarette. and if the patient is having difficulty in spitting the saliva.
Yes, sir.
So these would suggest a relatively earlier involvement or a milder form of, and history of sleeping with the eyes open during the night, which would be reported by the bystander, or the patient will just come with the irritation in the eyes, no other symptoms.
Okay, sir.
So in that case also, maybe we have to rule out a minimal facial weakness.
Okay, sir.
Yeah. Proceed.
Yes, sir. Sir, history of weakness in the left upper limb since 8 months. Patient noticed difficulty while combing the hair and brushing the teeth, and overhead abduction of her left arm, which was insidious in onset and gradually progressed. There was no history of difficulty in buttoning or unbuttoning of her clothes in the left limb. There is also a history of twitching movement she noticed in the upper part of her left limb since 4 months. Weakness is here also. Weakness is not associated with the pain and stiffness of the joints.
Here also pain you have to specifically mention at the neck in history wise.
Okay, sir.
And weakness of the upper limb for the past 8 months, and initially difficulty in combing of hair. Once again the same thing. Mentioned gripping, or whether it is lifting the upper limb above the head level.
Okay, sir.
Difficulty in brushing. So difficulty in brushing means whether he is able to, due to facial weakness, unable to expose the teeth and brush, or unable to grip the brush, or unable to lift the upper limb above to the level of the head.
Upper limb only, sir. Like she is not able to lift the upper limb to that mouth level.
He is able to grip the brush very well.
Yes, sir.
Okay.
Yeah, continue.
Sir, there is a history of difficulty in lifting the head in the supine position since 8 months, sir. Patient also noticed thinning of her neck since 8 months, sir. And there is a history of difficulty in rolling over the bed since 4 months. She is having difficulty in rolling over to the left side more than the right side, sir.
What does that indicate?
Sir, right obliques are involved more as compared to the left
elevating
side.
Of the head.
Yes, elevating of the head, her flexors of the neck muscles are involved here, sir.
The patient volunteered this information. There's difficulty in elevating, or did they say something else?
Sir,
what would the bystanders say, or flexors are weak? No? So what will happen when the patient attempts to get up from the bed? What would happen?
Head lag.
Yeah, the head would remain back in the bed itself, or the pillow itself. So head would be difficult. Somebody would have had to support it and lift it. So that history might come. Okay. Otherwise, to say difficulty in elevating from supine position, they might say it. I'm not saying it's not told, but yes, they can say the thinning of the neck and all they have told. They may be.
Yes, sir. Yes, sir. This is significant history, sir. He was only telling that neck muscle is.
Then possibly he has noticed that and telling that. So what are the diseases where this neck, your dropped heads occurs?
Sir, in inflammatory myositis, like inclusion body myositis, then sir, muscle
Which one inflammatory?
Sir, inclusion body myositis.
Anything other one other than that? Other than
sir,
inclusion
GB
body?
syndrome, it will be there, sir.
No, other myositis. Doesn't happen with polymyositis.
Polymyositis.
Okay, fine. Myositis, you said. Any other conditions? Commoner ones?
GB syndrome, snake bite, or OP poisoning.
OP poisoning, correct. Myasthenia?
Myasthenia.
You can get it in myasthenia. Yes, in your patient, MND?
MND also.
Okay, you can get it in these conditions also.
Yes,
again. So, it's not related to the cranial nerves?
No, sir. It's more of like, sir, cranial nerve only. But thinning of the muscles is also not there in the.
Thinning of the muscles is there. You know, sternocleidomastoid weakness.
Yes, sir.
What would it produce?
That swan neck deformity and.
Will it produce the symptom?
Sir, difficulty in turning the head.
Turning the head. Okay. Bilateral, if it is there, they may have the same symptom that could be there. Broken neck sign or the dropped head syndrome. And then you said the trunk muscles are also involved.
Involved, yes, sir.
Trunk muscles are involved. Difficulty in rolling over the bed.
Yes, sir.
Usually it's seen in asymmetrical conditions, or you get it more often with anything which is symmetrical.
Sir, trunk muscle involvement usually seen in symmetrical.
Here you're saying it's more on one side and all. The patient told you these symptoms specifically?
Yes, sir. Difficulty in rolling over.
To the left side more than the right.
She is having that gross OBS, right? Left side chest also. She is full.
No, that's what she has a significant weakness of the limb, isn't it?
Yes, sir.
Right limb is very weak.
Yes, sir.
So you will have to be little clear in saying whether the trunk also is like that, asymmetrical and all. It's little too much of a history, maybe. Yes, I'm not saying you can't get that, but then when there is a limb weakness, yes, there is always these coexisting problems may be there.
No, sir. And she is having that wasting of the pectoralis major also, sir. Significant. I'll tell in the A2 examination.
All those things are there, so it may not be just related to the rolling over itself.
Okay, sir.
Dr. Sharath, what is your take on these symptoms? Do you get so clearly histories?
Rolling, okay, but left side more than right side.
Yeah, that is a little too much, possibly. I think you can say that, but then I don't think so. You don't have to stress on it and write it in your case.
Okay, sir.
Yeah, proceed.
There is no history of difficulty in getting up from the squatting position, or there is no history of putting the slippers, holding, gripping, or removing the slippers. There is no
difficulty. You forgot to write the difficulty.
Sorry, yes, sir, difficulty. There is no history of any abnormal twitching movements in the lower limbs. There is no history of cramps or muscle contraction or enlargement of the muscle in the lower limb. There was no history of falls or swaying while walking or difficulty in walking in the dark. There was no history suggestive of thinning of the lower limbs. There was no history of tingling or painful or burning sensation over the upper or lower limbs. There was no history of difficulty in perceiving the hot or cold water while taking bath. She could be able to perceive the vibration of the mobile phone. There was no history suggestive of bowel and bladder involvement.
Okay. So what does it infer from here? This one, lower limb is completely normal?
Sir, on history wise and the history whatever she's giving, it's completely normal, sir.
What do you expect in the lower limb in this patient?
Some kind of rigidity or spasticity.
Rigidity?
Spasticity, sir.
Should have been increased tone.
Sir,
maybe. Okay. Anyhow, we have written that there is lower limb is completely normal. Maybe history wise you may not get it.
Yes, sir.
But then, okay, fine.
Other than stiffness of lower limb, patient might not straightforward till like there may be stiffness. So how would you expect? How would you extract the history of spasticity in lower limb?
Sir, difficulty in like climbing the stairs or putting the slippers.
And it can be just a change in the gait pattern.
Yes, sir.
Mild change in the gait pattern can also be there, which is early spasticity involved in the lower limb. Because the adductor spasticity is the initial spasticity which would be appreciated in lower limb. So there may be mild crossing or the patient may graze the feet while walking. So early spasticity can be made out by change in the gait. And if no history of swaying while walking, so you are meaning like ataxia.
Ataxia and sir.
Okay, so ataxia, like how would you like to why do you want to eliminate ataxia or include ataxia, or what you are inferring by eliminating ataxia?
Sir, here that bulbar involvement is there, sir. Cerebellar ataxia can be there, sir, because that is adjacent structure. But if it is any degenerative process, I'm suspecting in the bulbar, that can involve the cerebellum also.
Any other mechanism of ataxia in your patient? Muscle, no?
Muscle, okay. That proprioception. No,
proprioception is different. Muscle can produce ataxia?
Because of the muscle weakness.
Which muscles? The lower limb, which muscles, if they are significantly involved, the patient can have ataxia, no?
Sir, proximal muscle,
significant proximal muscle weakness.
Sir,
significant proximal muscle weakness, they can have ataxia. As you said, neuropathy, if it is there, you said the large fiber, sensory ataxia. Yes. As you said, degenerative cerebellum. Yes.
Yes, sir. There was no history suggestive of any cranial nerve involvement. Other cranial nerve.
Other cranial nerves. Yes, sir. Okay.
Sir, and there was no history of any cognitive impairment or emotional lability. And there was no history of tremors, sir. There was no history of difficulty in breathing. There was no history of seizures or headache. There was no history suggestive of any toxin exposure or heavy metal exposure and any drug exposure. There was not there was no history of significant weight loss. She was
This
given
is one thing that you have to again check it on.
because of liquid food she's
It
taking.
is 2 years duration and she's not been eating and all those things.
Yes,
Weight
sir.
loss should be there. And you said she has become thin also. It's very surprising that she doesn't have weight loss.
And cognitive impairment, like what are you inferring? Why do you
Sir, any difficulty in naming or any impaired in the daily activity and uh, naming or any memory disturbances?
like it is like till now whatever you told is like a pure motor syndrome.
Yes, sir.
Like what do you want to bring in the cognitive impairment?
Sir, here motor symptom is there and patient is young patient. If it is associated with the degenerative process in cerebral cortex also like frontotemporal dementia and all. So,
So other than cognitive, yeah, you can mention like you can specifically mention behavioral disturbances.
behavioral disturbance. Okay, sir.
Most of difficulty in breathing.
Sir, sir, basically to rule out any diaphragmatic involvement.
Okay, very good. So rather than like difficulty in breathing or the patient difficulty in breathing, some problems like in the case of intermediate point of weight loss, in case of difficulty in breathing, very early stages of diaphragm involvement, patient do not have any breathing during awake.
Okay,
And
sir.
in between the night, they will generally get to wake up in between the night and they
Okay,
will
sir.
forever and breathe. And in some patients, even this mild chronic diaphragmatic weakness can lead to CO2 retention. And so they will have early morning headache. And during daytime, they will have excessive daytime somnolence. They will be sleeping from the time to the CO2 retention. So in that case, patients do not complain of any breathing difficulties, but these are some soft early morning headache and daytime somnolence. It can suggest a very early involvement of the diaphragm. So instead of difficulty in breathing, you can probe in there. At least of headache, even go to retention can cause headache. Are you there, Raghu?
Yeah. Hello. I think we've lost. And we'll wait for him to join back. Any questions anybody else has? I think you can type in the chat, or if there are any doubts so far, Vijay, is he joining back?
I think he lost little connection, sir. I think he's joining back. I'm just contacting him, sir.
No questions on YouTube, no?
No, sir. One question was, can loss of nasolabial fold be one of the initial signs of facial nerve weakness? Like, for example, pressing over the frontal sinus to check for the initial stage of facial nerve palsy.
Maybe that's on examination. I think we were discussing on history. I think Dr. Sharath was discussing on history. How will you make out early? Nasolabial fold definitely on examination, I think is a finding which can be detected early.
Hello. Hello, sir.
Slides are visible.
Sir, sorry, sir. Wi-Fi went off in the hostel, sir.
Yeah, no problem. Yeah.
Sir, there was no history of there is no history of difficulty in breathing. There is no history of seizures or local loss of consciousness or headache. There was no history of exposure to any toxin or heavy metals or any drugs. There was no history of significant weight loss, sir.
The toxins, like what toxins we expect are heavy metals?
Sir?
You have mentioned no history of exposure to toxins or heavy
Yes,
metals.
sir. Yes, sir. Sir, arsenic and lead toxins can be used.
Okay, those are mainly the motor neuropathies. So lead is
Yes, sir. Yes, sir.
asymmetric pure motor neuropathy, especially involving the upper limb, causing wrist drop. And arsenic?
Sir, arsenic usually motor and sensory involvement is also there, sir, and distal.
Yeah, motor predominant and sensory motor neuropathy. And other things which you would expect in arsenic intoxication. Mainly the skin changes, the raindrop pigmentation on. Hello.
Hello, sir.
Yeah. Didn't.
Yes, sir. Sir,
Yeah.
arsenic and nail changes will be there, sir, along with that motor and sensory.
Yeah. And skin changes and nail changes. Those
Yes,
will
sir.
be there. And the history of weight loss, regarding in what context you are asking?
Sir, any malignancy, paraneoplastic syndrome we are suspecting. That's why I asked weight loss here, sir.
Okay, malignancy leading to.
Paraneoplastic syndrome, like.
Okay, other thing.
Because of that repeated nasal regurgitation, that can also lead to the weight loss.
Yeah, that can cause. And another thing, as you rightly said, is the malignancy. So malignancy elsewhere in the body, and you are mainly telling like bulbar and upper limb affliction.
Yes,
So
sir.
you are mainly referring to the craniovertebral junction.
Yes,
So
sir.
if you want to localize both the upper limb symptoms and the bulbar dysfunction to a single point, so
Yes, sir.
one most probable thing would be this craniovertebral junction location.
Yes, sir.
Tumors involving the craniovertebral junction or a metastasis to the craniovertebral junction can lead to this kind of picture.
Yes,
And
sir.
in that same context only, I wanted to ask you regarding that swaying while walking.
Yes,
So
sir.
apart from muscle disease, even the cerebellar involvement can lead to gait ataxia.
Okay, sir.
And in that case, if you are suspecting the craniovertebral junction kind of phenomenon, it would be better to mention regarding the ptosis of history of drooping of the eyelids, because Horner syndrome is expected in craniovertebral junction.
Okay, sir.
So why we are bringing in all this is because you have a syndrome of both bulbar
Upper lip
involvement and upper lip
upper
involvement,
cervical.
which both these both two combination are very much possible in a case of a craniovertebral localization. So
Yes,
in that case, better to put on this ptosis history also.
okay, sir.
And the history of seizures, loss of consciousness, or headache. Headache again can be due to chronic CO2 retention.
Okay.
And in other context, like you kept a headache for the same thing, CO2 retention, right?
Yes, sir. One to CO2 retention or any same thing, sir. Raised ICT because of any tumor.
Okay, okay. A history of tremors.
Sir.
These patients you can present like these patients you have mentioned thinning of the limbs also, I think.
Yes, sir.
So sometimes they come up with the history of tremulousness of the hands, especially. So, like, what would you expect? Like, what are you inferring from that? It is not a true tremor, actually, what they historically tell, but it
Yes,
is a neuropathic tremor that is due to severe weakness or due to severe wasting of the muscle, or it
yes,
can be due to a fasciculation, which can cause a, but usually it is an isolated finger, involves a single finger.
yes, sir.
Fasciculation can cause a fine single this involvent movement involving the single finger, or it another thing is the severe neuropathic tremor in case of severe neuropathy or a severe weakness,
Yes, sir.
which we call it as a polyminiumyoclonazole.
Okay.
And history of giddiness or vertigo.
Sir, giddiness or vertigo, sir, eighth nerve involvement only, sir, and any, sir, whatever, sir, sir,
So again, the same thing
yes,
as your syndrome is basically involving the bulb, that is the
yes,
bulbar, the middle
yes,
oblongata and the upper lips.
yes,
So
sir.
again, extension into the little above the middle oblongata can also lead to involvement of the eighth nerve and again
Yes, sir.
cause a vertigo or
Yes,
hearing disturbances even. So currently
yes,
we don't know what is the lesion. Our
yes,
probable localization as per its history, there is no history to suggest any UMN finding,
yes, sir.
and there is no history to suggest any sensory finding.
Send, sir.
So it is a pure motor syndrome without any
Yes,
bowel or bladder involved.
yes, sir.
And autonomic symptoms also better to mention in the history of palpitations or
Okay,
history
okay,
of
sir.
darkening of vision immediately when getting up
Okay,
from the supine position,
okay, sir.
or history of pre-syncope kind of thing or a syncope.
Okay, sir.
And so according to your history, it is basically a
Pure motor asymmetrical chronic progressive.
chronic progressive pure motor syndrome, mainly LMN,
Yes, sir.
involving the bulb and the
Bulb and cervical region, upper limb, sir.
okay, okay. So I think next slide you will be summarizing it.
Sir, past history, nothing significant, sir. Like 1 year back, they done the MRI and was told to be normal, sir. MRI spine was done, was told to be normal, sir.
Okay.
Proceed.
And family history, yes, sir.
Yeah, proceed.
Yes, sir. Family history, sir. No one in the family will be are having this similar complaint, sir. No one is in bedbound or using walking aid, sir. This was the
What
family
more you will ask
complaint,
in family history?
sir. Sir, here in this case, sir, sir, any,
You only mentioned
yes,
regarding
sir.
entities previously when
Yes,
I
sir,
was
yes, sir.
asking about cognitive dysfunction.
Yes, sir. Okay. Like any dementia in the family members, you should ask, Dr. Yes, sir.
Cognitive disturbances or movement disorders in the family members, because even this Parkinsonism, atypical Parkinsonism is associated with in few genetic conditions with the ALS. So especially the PSP phenotype can be seen in patients
Yes,
with
sir.
ALS, especially in genetic ALS.
Yes,
So
sir.
in
Yes, sir.
history of movement disorder or history of bradykinesia or any
Okay, sir.
atypical Parkinson's, gait disturbances in family members or cognitive dysfunction in the family members.
Okay, sir. Okay. So personal history, consumes mixed diet, sir. Appetite is normal. Sleep is adequate. Bowel bladder habits are normal, sir. No history of any substance abuse or alcohol intake, sir. There is no history of any exposure to the toxins, sir.
This syndrome, like exposure to toxins, again,
Sir,
just apart from the arsenic and the lead thing we have mentioned, so any
yes,
any
sir.
relevant exposure
Denture,
pertaining to this,
dent, any, sir, dental denture usage, or that can lead to the zinc lead to the copper deficiency or and
one more thing is that initially, like one of
any
our
organophosphorus chronic exposure.
okay, that too initially previously it was described like a pesticide exposure is more associated with this motor neuron disease, but now currently it is not such a kind of thing. Previously, when this disease was early evolving during the research period, it was thought that pesticides were the main causes of this motor neuron disease. But currently, there is no such thing.
Any other toxin, if you say food-related toxins, which can cause pure motor?
Sir, botulinum and lathyrism.
Botulinum?
Sir, lathyrism.
Lathyrism.
But here that lower limb involvement will be more, sir, and spastic type kind of feature.
Isn't it? Spasticity. That is one thing which you have to remember. Yes. Proceed.
Sir, summary: 37-year-old female without any significant past history or family history, presented with chronic progressive asymmetrical upper limb weakness with both proximal and distal muscle in the right upper limb and proximal muscle in the left upper limb, with significant history of wasting of neck and hand muscles with the fasciculation, with progressive bulbar palsy, without lower limb weakness, without sensory autonomic bowel bladder involvement. Sir, at the end of the history, I would like to consider my differential diagnosis as first differential. I would like to keep it as a motor neuron disease only, sir. And and second differential, bulbar poliomyelitis. And third, sir, even though cranial vertebral anomaly, there is no lower limb involvement, sensory system is not involved. Very unlikely, but I would like to keep that as a another differential diagnosis, sir.
Which is the most common entity?
Sir?
Which is the most common entity or the most common differential diagnosis for the motor neuron disease?
Sir, cervical spondylosis.
Okay, why you would not like to consider that in this case?
Sir, any compressive lesions are without involving the lower limb, only involving the upper limb. That is.
I think we can explain. Okay.
Yes, sir.
Any other point against the cervical cord compression?
Sir, pain. Though I didn't take the neck pain history, but she was not giving the history of pain or any lermiticine kind of feature, sir. And
okay. Any other thing?
Young patient, sir.
This even patient has this bulbar palsy, which is
yes, sir.
higher up above the cervical.
Yes, sir.
Bulbar poliomyelitis, why like
that? Sir, that can, sir, though,
yeah, it can
sir, bulbar poliomyelitis, even bulbar, asymmetrical and motor predominantly.
Yeah, but that is a relatively acute to subacute process rather than a.
Yes, sir. Yes, sir.
And any other entity related to polio, which can cause a chronic progressive motor weakness. So there is an entity known as post-polio syndrome.
Yes, sir.
Which can again lead to asymmetric onset motor weakness, which is gradually, slowly progressive. So that can cause in a patient who had a previous history of poliomyelitis, after few years of the illness, like around 2 decades after the insult of the poliomyelitis, patient can have gradually progressive weakness, asymmetrical onset, pure motor syndrome, LMN syndrome. But that is also a gradually progressive.
Yes, sir.
So bulbar poliomyelitis is acute to subacute entity. Other things, vertebral anomaly.
Sir, sir, syrinx, but here a sensory involvement is not there, sir.
Sensory, historically, you may not get the sensory accurately. So, I think better would be consider first a craniovertebral localization, because it is always better to consider a treatable entity first. And even as per the incidence, also craniovertebral anomalies are also relatively more common than motor neuron diseases.
Okay, sir.
So what are the points? So how would you support yourself for motor neuron disease or a craniovertebral anomaly, or points against motor neuron disease or craniovertebral anomaly? Or would you like to consider any other entity here? So the picture you have is a pure motor element syndrome involving the bulb and the upper lip. So points against motor neuron disease, points against craniovertebral anomaly, points for motor neuron disease, points for craniovertebral anomaly.
Lost him again. Hello.
Hello, sir.
Yeah.
Sir, here it's a chronic progressive asymmetrical involvement is there, sir. Wasting is there, sir. Fasciculation is there. So I can consider motor neuron disease. No, sir.
They are the features for motor neuron disease. Okay.
Yes, sir.
What are against motor neuron disease? Any features which are not favoring motor neuron disease?
Sir, in the history till now, I have not mentioned any upper motor neuron disease. Sir.
Okay. UMN sign history wise is not there. Okay.
Not there, yes, sir.
Like what are the features favoring high cervical correlation, C-way junction? What are the features against?
Sir, see, features against is bulbar. It can involve bulbar involvement.
Bulbar is featured favoring.
Yes, sir. Sir, lower limb involvement is not there, sir, and sensory involvement is not there. Only motor and asymmetrical. It's bit unusual for craniovertebral anomaly, and there was previous history of back pain is not there, sir, and sorry, lower neck pain is not there.
Okay.
And any history of usually that follows a trivial history of trauma, then they present like acute presentation will be there, sir. In chronic.
What else in a spinal cord disease will get involved? Going on for 2 years now. Bladder. You would have. Again, remember motor neuron disease, for whatever reason, purpose, the two groups of muscles which are not involved in motor neuron disease. Traditionally, two groups of muscles do not get involved in motor neuron disease.
Respiratory and bladder.
Respiratory is involved. Respiratory gets involved. Bladder, the sphincter.
And cardiac.
Sphincter is not involved. One more is
cardiac.
Extraocular muscles. Okay. Extraocular muscles and the sphincter is not so involved in case of motor neuron disease. If it is there, then it's something else. That is what you'll have to think of. So supposedly we're talking a young patient who has come with a motor neuron disease sort of features, and it has been going on within a year or so. It's extended, progressed pretty rapidly. What else do you want to consider?
In young patient, motor neuron kind of.
No, this is the age, but still progression is a little rapid. Anything association you want to consider? If it is an elderly 70-year-old male, what do you want to consider?
Paraneoplastic.
Paraneoplastic in elderly. In young patient, which is the disease?
Sir, hereditary.
Okay, that is agreed. That is motor neuron disease. I agree with that. Okay. Other than that, any other condition which could be associated, which can have this wasting, weight loss? Infectious disease.
Lyme's disease.
Lyme's is not common in India.
HIV.
HIV.
Yes, sir.
HIV associated MND.
Yes, sir.
A lot of reports of HIV associated MND, younger patients, and they do improve after treatment of HIV. There could be some significant improvement. Okay, you should always keep it in your mind that it has to be ruled out. But yes, this is the age of presentation. I'm not saying it's this one. MND still, but you have to rule out, as Sharath already mentioned. The first thing that has to be ruled out is a treatable condition, that is your compressive myelopathy. That's why a CVJ would be a little higher. Better to be putting CVJ higher than motor neuron disease. Okay. The CV junction anomaly higher than the motor neuron disease, though we have points against it also, but still always put a treatable condition a little higher. Okay, sir. And as you said, 1 year back MRI done was normal. Maybe that could be used for that, saying that yes, it has been evaluated and compression has been ruled out a year back. Okay. But put it up, put that up, and then motor neuron disease second.
Sir, can I go to the examination?
Yeah.
Yes, sir.
And one more thing, Raghu.
Yes, sir.
Yeah.
How can you explain this like severe wasting and fasciculation in a case of suppose if here there are many points against this EV junction anomaly, but if craniovertebral anomaly is there, how would you explain the findings of wasting and fasciculation in upper lip? Bulbar is okay, straightforward. It can directly compress the medulla and cause the symptoms.
Okay, sir.
Whereas the upper limbs they correspond to around T5 to T8 T4 or T1 extent of the cord, and whereas the lesion is well above the near the medulla.
Okay, sir.
So why is there wasting? What is the mechanism? Can you explain?
In craniovertebral anomaly, sir.
Or supposedly there is a compressive myelopathy at a higher level.
Yes, sir.
You can get wasting at a lower level. Acutely,
disuse,
how do you get it? Or chronically, what is the mechanism?
Sir, chronically disuse atrophy.
No, disuse atrophy is on the side of weakness later.
Yes, sir.
We're talking about pathologically what happens there. At a higher level, if there is a lesion, you get wasting at a lower level. C1, C2 is the lesion, but you're getting wasting
because
in
of the venous congestion in the
acutely it could be venous congestion.
Venous congestion.
Chronically, what is that problem that can happen? Chronic compression
Yes, sir.
can result in what problem in the spinal cord?
I'm not sure, sir.
What is
Venous
the degeneration of the spinal cord? What's the technical word used for it?
Sir, in Narus, Valerian degeneration, but spinal cord.
Yeah, that's what's the word used there?
I don't
know.
Milo. I don't know, sir.
Myelomalacia, you heard?
Myelomalacia. Okay, sir. Sir. Thinning of the spinal cord.
It can cause. Okay, so chronic can cause, but so much of wasting, so much of this one is a little less likely in that.
Okay, sir.
Fine, you can proceed to the examination.
Yes. Sir, general physical examination. Patient is right-handed, conscious, cooperative, well-oriented to the time, place, and person. She is moderately built and nourished. Her VMA is 18 kg per meter square. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or bilateral pedal edema. BP is 120 by 76 mm of Hg taken in the right arm in the supine position. There was no orthostatic hypotension, sir. Pulse rate is 72 beats per minute. All peripheral pulses were felt and no special character. Respiratory rate is 18 cycles per minute. It was thoracoabdominal type. Sir, and single breath count, sir, since she was having that difficulty, I couldn't count the single breath count, sir. Head to toe examination. Sir, there is a temporal hollowing is present. No Bell's phenomenon. No neurocutaneous marker is. Hello, sir.
Yeah, continue.
Yes, sir. No neurocutaneous markers. No cutaneous markers of malignancy is present. There was no wasting of this. There is a wasting of small muscles of the hand present bilaterally. Wasting of the pectoral is major present on the right side. Sir, yes, large swelling measuring 9 to 7 centimeter present over the nape of the neck in the subcutaneous plane, and fasciculation seen in the left side of her neck at the time of examination, sir. I have the video, sir.
What is that large swelling?
Sir, she was saying it present only in the 2 years only, and the doctor told it was lipoma, sir.
Okay, you'll have to infer. You will have to write an inference there.
Okay, sir. Sir.
Why it is a lipoma, some sign you'll have to say. Otherwise, it's only small muscles are wasted in the hands.
Sir, so wasting, sir, remaining.
Proximal is not wasted.
Sir, sir, I couldn't appreciate that much of proximal wasted.
Both sides are.
Sir, sir. Sir, this was her photo, sir. The temporal hollowing is present.
Okay.
And this was her hand photo, sir. We can see the guttering in the central area and hypothenar wasting, we can see, sir.
Hypothenar wasting. What happens in ALS classically? Which gets wasted?
Hypothenar muscle involved. That split hand syndrome is there, sir. Hypothenar muscle. Sir, basically the T1 ulnar segment of the muscles are atrophied compared to the thenar muscles. Sir.
Which muscles are more affected than the others in split hand?
Hypothenar muscles.
Hypothenar or thenar?
Sir, ulnar component hypothenar muscles.
Which fingers you will use the most in your daily routine activity?
Sir, thumb only, sir.
Thumb.
So it is the thenar and the FDA, first dorsal interossei, which are wasted with this.
Abductor pollicis brevis and first dorsal interossei is more involved in split hand. Okay, fine. Okay, the small muscles are wasted.
Yes, sir.
Right. Can you list some causes of small muscle wasting?
Sir, the peripheral neuropathy, diabetic neuropathy, and any cervical rib or Herb's palsy, congenital Herb's palsy, and ALS, motor neuron disorder, and
More important.
Pankot's tumor.
Okay, Pankot's tumor. More important.
The one which you have put in the deed is one of that entity can cause a similar
Multifocal motor neuron with variable conduction.
Okay. Any problem in the spinal cord which produces wasting of the small muscles of the hand?
Cervical spondylosis.
Okay,
cervical rib and
in the spinal cord, intramedullary lesion.
Okay, sir. Syringomyelia.
Okay. So always start from there and then come to the anterior horn cell. After the anterior horn cell, as we have discussed that time, the radicals, the diseases which affect the radicals, and then the plexus, and then the nerve, and then the muscle. So you can have this. This is a very common question they ask you. Wasting of the small muscles of the hand. What are the causes?
Okay, sir.
Other thing in examination, general examination, you would like to highlight anything? You have missed anything? Again,
general physical examination, sir. Any skin changes or nail changes? I should have mentioned, sir.
Okay.
And basically the examination must consolidate whatever history you have got, and we must be able to consolidate the findings on your history. So in your DDs, you have mentioned a TV junction.
Yes, sir. Low neck, low hair sign, and neck to body ratio. I should have taken, sir.
All should be taken. What are the markers of TV junction?
Hello, sir.
Hello.
Sir.
What are the markers of the craniovertebral junction?
Sir, low hairline and that body into neck ratio.
Neck to height.
Neck to height ratio less than 1:13.
What else?
And sir, cripple plane syndrome, like any spine, scapular deformity.
What is that? What do you call that as?
Clippal plane deformity. Sir.
Okay, clippal field syndrome. Okay, you can have a short neck. You can look like a field stride can be seen. What else on the scapula? Anything can be seen?
Level of the scapula.
Anything happens there?
Don't know, sir.
Undescended scapula.
Okay, sir.
Pharyngeal deformity.
Pharyngeal deformity of the scapula.
Any other markers? These are the most common usually we discuss, but there are other markers, like you might have any tuft of hair over the same area, or you can have crowding of the teeth, and even the Horner syndrome is also one of the things which would suggest, and higher palate. Okay. Kyphosis scoliosis can be there. Short stature. Short stature because even in craniovertebral junction anomalies like invagination of the skull base, you can have, or a platybasia, you can have compression of the pituitary, which can lead to hormonal deficiency. Growth hormone can lead to short stature. Okay, so your history was like involvement of the medulla and the involvement of the both upper limb. However, the odd points were there for a craniovertebral localization. Yes, but the upper limb distal wasting and bulbar involvement, which fairly can potentially localized to a craniovertebral junction. Yes, sir. However, there is no ataxia because craniovertebral junction anomalies can present as a pure motor syndrome or a pure ataxic syndrome or a pure bulbar syndrome and a mixture of these entities. But with the involvement of the human science will make it hard. However, on examination, we will see.
Okay, sir.
So general examination, better to mention, especially in case of this upper limb involvement and small muscle wasting. The craniovertebral junction anomalies like even congenital malformations like ACM, Arnold Chiari malformation can cause syringobulbia and syringomyelia, which can explain your bulbar symptoms as well as your small muscle wasting of the hand.
Yes, sir.
What general examination finding you will get in the eye?
Sir,
CV junction.
Cataract, CV junction anomaly, sir.
Not general examination. It's Horner's correct. Yes, anything else? Any other nervous system only, but in the eye, you might get it on inspection itself. Any type of nystagmus?
Yes, sir.
What type of nystagmus? CV junction.
Movement. Don't know, sir.
Anybody else can type it or tell? What is downbeat nystagmus? Hello?
Sir.
Downbeat nystagmus, what's the localization?
Sir, medulla downbeat.
Medulla. Okay, proceed.
Yes. Sir, this was the swelling I was telling, sir.
Okay.
And sir, yes, sir. Sir, this was the fasciculation I got at the time of examination.
Okay. Fasciculation. Which muscle was it on?
Sir, platysma.
Platysma. Okay. Fine. Where else the fasciculation was there? Only in this region?
Sir, in history wise, she is having deltoid and in both the upper limbs and forearm muscles also.
Okay. It was there in the other muscles also.
Sir, I couldn't record those.
You couldn't record. Okay.
Higher mental.
Yes, causes of fasciculations, other causes?
Sir, it can be benign also, and then
motor neuron disease is there, other causes.
Then any degenerate, sir, any nerve injury, and
common emergency handle.
Sir, OP poisoning.
OP poisoning, correct. Endocrine disease.
And hypothyroidism and hyperthyroidism.
Not hyperthyroidism. Hyperthyroidism. Okay. If you do not get the fasciculations, can you induce?
Yes, sir. By hyperventilating, I will make them talk. Talk more. We can induce.
Exercise. Huh?
Yes, sir. Exercise or
caffeine or sympathomimetics. Okay, sympathomimetics, caffeine can increase, especially benign fasciculations get more pronounced once they have a cup of coffee.
Yes,
okay, so fasciculations is there in this patient. Okay, continue.
Yes, sir. Sir, GCS is 15/15. Sir, patient is conscious oriented. Memory is intact. Sir, recent remote memory. Intelligence is normal. Sir, no delusion or hallucination. Speech, sir, nasal intonation of the speech was present. MMSC was 19/30, sir. I have that recording of that speech, sir.
Okay, why is that 19/30?
Sir, she was illiterate, sir. She was not able to do that calculation part and writing.
Okay. Maybe you can't use the MMSC.
Sir, sir, what should we use, sir? Can we use that local?
No, that's what. See, again, remember, MMSC is already, it's a patented thing, copyrighted thing. So we cannot use it straight off. Okay, but clinical discussions, we can still use it. Okay. But then when the patient is illiterate, I think it's better to say the individual components and say how it is. Okay. Because reading, writing, all those things will become difficult.
Yes, sir. Yes, sir. Yes, sir. Okay. Sir, this was the speech, sir.
Yeah. think it's a little faint. It can't be heard that well. Okay, we'll agree with you. Nasal intonation, we're agreeing with it. Yeah.
Yes, sir. Sir, cranial nerves, sir, olfactory was normal, sir. Optic, direct, indirect, and fundus was normal, sir. Third, fourth, sixth nerve was normal, sir. Trigeminal nerve, sir, motor and sensory component was normal, and jaw jerk was absent, sir. And facial nerve, sir, orbicularis oris was normal, uh, and orbicularis oculi was also normal. Sir, buccinator, she is not able to puff, make the puff, sir. She is not able to. Buccinator are weak, sir. And taste anterior two-third was normal. Eighth nerve was normal, sir. Ninth gag reflex was absent, sir. So 10th palatal arch was symmetrical and position of the uvula was in the center only. And 11th, sir, sternocleidomastoid was weak and trapezius was normal, sir. And 12th nerve, tongue atrophy was not there, sir. Fasciculation was there and tongue muscle weak, it was weak, sir. This was the video.
Which cranial nerves you want to highlight in this area?
Sir, 9th, 10th, 11th, 12th, all are bulbar cranial nerves are involved, sir.
Any other cranial nerve which you would like to focus on, especially pertaining to this patient, till whatever we had?
5th and 7th nerve can involve.
Again, the same, third and fifth also, because third dose is as we are thinking of your DD was craniovertebral junction anomaly.
Okay, sir.
So, and another thing is the fifth nerve sensory, because
Yes,
fifth nerve sensory nucleus can extend down the C1 to C2 length.
okay, sir. Sir, this was the tongue. Sir, tongue was thin, sir, as we can see, and we can see the fibrillation.
Fasciculation.
Fibrillation, sir.
Fasciculation. Fibrillation. Fibrillation is.
Sir, in tongue muscle we can see no, sir, fibrillation.
Yeah, but it's usually the fasciculation which
fasciculation.
Okay.
We say fasciculation.
Okay.
She's not able to protrude the tongue out, you said, no?
No, sir. Sir.
Yeah. Okay. Fine.
Sir, motor system, attitude, she was lying comfortably in the bed. Sir, arm, bulk, sir, arm, there was no gross asymmetry between in the upper arm, sir. And forearm, right side it was 18 centimeter and left side it was 21 centimeter. And lower limb, there was no gross asymmetry between the two limbs, sir. Only the forearm wasting is more in the right, right upper limb, sir.
How do you check the bulk test for that?
Sir, measurement, sir, from the arm, olecranon, 10 centimeter above and below from the olecranon forces for the upper arm and forearm respectively. In thigh, it is 18 centimeter above the upper border of the patella, and leg, it's 10 centimeter below the tibial tuberosity.
So that is what we usually do. But other thing is that you have to take the measurement on the limb on a 2 points on a 2 points you have to take on a bone. Suppose if you take the leg, you can take the medial malleolus or lateral malleolus and the tibial tuberosity.
Okay, sir.
2 bony points, not crossing any joint, and take the midpoint. That is usually scientifically mentioned. However, we can use this one.
Okay.
So, as you said, olecranon is part of the forearm or arm?
Sir,
olecranon is part of forearm or arm? Forearm, isn't it? So it's preferably to pick a bony point in the measurement region. So for the arm, you could pick up the humeral condyles or something like that. Okay, that would be better.
Okay.
Yeah.
Sir, tone, sir, in upper limb it is reduced in all joints, sir. In lower limb it is normal only, sir. Normal, or I would say it's hypo or normal only, sir. It's not hyper tone.
Better to say it is reduced.
Sir?
Reduced. Don't use the word reduced at all the joints. Huh? Just say it's hypotonia in the upper limb.
Okay.
Yeah. I think Sharath is asking.
Yeah, lower limb tone, how did you check?
Sir, I check by rolling the limbs over the supine, and also we can just elevate the limbs at the knee joint and leave it like that only. If it is a flaccid limb, it will come to the bed as soon as we leave it. If it is spasticity, sometimes it can that foot will come spastic.
Any other myth?
What do you expect in the lower limb in this patient?
Sir, after examining the reflexes, I expected spasticity, sir. After examining
you
the
expect
reflexes.
you expect
Reflexes,
it to be increased, so you have to carefully look for it. Okay?
Yes, sir.
Especially the adductor spasticity, you have to definitely look at by passively abducting the hip.
Okay.
That may be the only finding.
Only thing, yes.
Okay.
Individual movements at the not the flexion extension, because generally we tend up to doing the flexion extension at the hip and the knee. So you'll have to do the other movements also and look for, because you have to get some increased tone for your supporting diagnosis.
Sir, power, sir, in right at the shoulder level, it was 1/5 in all the directions, sir. In elbow, it's 2/5 in flexion and extension. Wrist was 2/5 on the right side, sir. Hand grip, sir, it was 3/5, sir. In the left, it was 2/5 at the shoulder joint in all the and in the flexion, extension, abduction, adduction. Internal and external rotation, it was 3/5, sir. Elbow, it was 2/5, sir. And wrist extension and flexion, it was 4/5, sir. And hand grip is 5/5 in the left upper limb, sir.
It is asymmetric pattern.
Yes, sir, asymmetrical. And sir, small muscles of the hand, sir, palmar interossei and dorsal interossei and abductor pollicis brevis and opponens pollicis all are weak in the right side, sir. Left side, it was normal, sir.
Other muscles also, it's all muscles, na? You just mentioned only 4 here. It looks like only selectively they have got involved. So it's all small muscles. Na? It's better to say it as all small muscles rather than mentioning. Okay.
Sir, and neck flexion is weak, sir. Extension is normal. Hip, sir, it's lower limb power is normal, sir, in all the joint level. And trunk muscle, she is not able to get up from the supine position, sir. And reflexes, sir, in biceps, it's absent. Triceps is absent on the right side. And supinator is 1+. And in the left upper limb, biceps is 1+, and triceps is 1+, and supinator is 2+. And knee and ankle clonus was present, sir. And Wattenberg and Hoffman reflexes was present, sir.
Okay.
Sir, this was the video, sir. You can see the flexion and
has to be flicked a little. You're keeping flicking has to be on parallel. Okay. Anyways, okay. This is Wattenberg's.
Wattenberg, sir. Sir, the thumb is flexed only, sir, in both the limb, upper limb.
Okay. Both the. This is the left hand. The left hand. You told left hand not much wasting and all. It looks wasted.
Sir, bilateral, it was flexion only, sir. At the
yeah, there was little. There is wasting in the left side also.
Sir.
Yeah.
Sir, this was the clonus, sir.
The video is getting stuck, but that's not the right way to do the clonus. Better not show it. Okay.
And superficial reflexes are normal, sir.
Plantar?
Sir, plantar also normal only, sir. It was downgoing, sir.
Downgoing on both sides, huh?
Yes, sir. Sir, then sensory system, both anterolateral column and posterior column sensations are intact, sir, normal bilaterally. And there was no cerebellar signs. Sir, gait was normal, sir, but speed of walking is reduced, sir, and arm swing is reduced, sir. Skull and spine was normal, except that she's having that lipoma over in the nape of the neck, sir.
Is there relevance of the lipoma of the root of the neck?
Sir, in case any mitochondrial or any association, if it is there, I'm not sure, sir. I just mentioned here.
No, it is. Is it associated with any?
Sir, they say mitochondrial muscle weakness can associate with lipoma.
Like tuft of hair, na?
Yes,
What is there for a spina bifida occulta there? So something like that. You could have lipomas, but this is too big and it's in the cervical region possibly. You could have such things in the spinal regions. You ask the patient to cough and check. There is no cough impulse there.
No, cough impulse is not there, sir.
Fine. Okay.
Sir, other systems are normal, sir. And the diagnosis, sir, it's a chronic progressive asymmetrical flaccid brachial diplegia with a significant history of wasting of neck and hand muscle with fasciculation, progressive bulbar palsy with UMN type of involvement in the lower limb without sensory, bowel, bladder involvement. Sir, at the end of the examination, I would like to consider motor neuron disease only, probably ALS variety.
Why is the plantar flexor?
Sir, superficial reflex.
What do you expect in a upper
Sir,
motor?
upgoing.
Yeah, because your reflexes clonus is there, you said. So generally you expect it to be extensor. No? So extensor is a more stronger feature.
Yes, sir.
You have to explain why is it flexor. That is the only thing. There's no weakness of the.
Sir, power is 5/5, sir.
Yeah, that's what. There's no weakness of the extensors. Nothing is there weakness. But why is your plantar flexor? So that is one thing which is not favoring. Okay. But yes, all the other features are favoring. You have exaggerated reflexes and some, you said, plantar equivalents you showed in the upper limb, isn't it? You showed Wattenberg and Hoffman's you showed. So plantar equivalents are there.
This abdominal reflex, what would you expect to be?
Sir, in female patient, usually that lower part of the abdominal reflexes are absent, sir.
In this disease?
Motor neuron, sir, if it is a upper motor neuron, it should be absent.
In MND, what happens to abdominal reflex?
Absent only, sir.
Really?
Sir.
Generally, it is preserved.
It is preserved. It is preserved. Okay. It's one upper motor neuron disease where the abdominal reflex is preserved. That's what, like traditional, what a question it is, which is asked.
Especially the degenerative conditions like motor neuron, if you take any hereditary myelopathy, so there you can have this intact abdominal reflexes. And, any other differential diagnosis?
Sir, in ALS variety only, that Hirayama disease can be considered, sir, in this patient.
Hirayama is a complete
monomelic.
Sir, but sir, only that upper limb involvement without.
So here on your examination, there is upper limb, there is bulbar, there is lower limb also. So it cannot be any of those monomelic types of things.
Okay.
So again, this TVJ kind of which you have mentioned in the TDs.
Yes, sir.
You have found evidence of spasticity or you have found clonus in lower limb.
Yes, sir.
So UMN finding is also there, although the bladder is there, not inward. But that should be also a potential diagnosis what I feel.
Okay, you should still rule out. You should still say that has to be ruled out.
Because examination also you have not stressed on the markers of TVJ. So we don't know the status. And then predominantly this is like UMN findings are there, but predominantly an LMN syndrome. It's a very few UMN findings in the form of just ankle clonus. Okay. And any other conditions which mimics of motor neuron?
Sir, multifocal motor neuron disease with variable conduction.
Multifocal? Multifocal what? Motor?
Motor neuropathy with
multifocal motor neuropathy.
Yeah, with variable conduction block.
Okay, with conduction blocks. Okay, that is one. Okay.
Then CV junction anomaly, cervical spondylosis.
Yes.
Syringomelia and
post polio, progressive muscular atrophy.
Next, so subacute combined degeneration.
Subacute combined degeneration of the cord.
Okay,
Yes.
subacute combined.
Where you can have myelopathy and neuropathy. You can have both.
Okay.
The sensory will be also be involved in post-relate reports.
Okay.
Vibration and can also be there. So that would differentiate the subacute combined degeneration.
Okay.
Could it be CIDP?
Sir, CIDP, sir, usually sensory involvement is also there, sir, and usually it is a distal and proximal involvement will be equal, sir. It involves the both
More
distal and
proximal, chronic.
Hardcore point is not
and symmetrical
Strong features
involvement.
against in the lower limb.
Symmetry,
correct.
and brisk reflex is also
Reflexes should be absent. And on general examination, you might find what?
In CIDP, sir.
Yeah.
Nerve? Autonomic involvement.
Yeah, that could be there. Nerve thickenings, isn't it? Nerve thickening. One of the common findings that you could get in CIDP. Okay, and again, generalized areflexia. Motor predominant, it will be motor. Sensory, as you said, it will be there, but motor.
Only
okay?
large
CIDP also has to be thought. But here you have definitely UMN signs which are there.
Bulbar
involvement is there, yes. What any other investigation has been done?
Sir, we have at the high heavy metals level, sir, it was normal, sir, and thyroid level was normal.
Okay.
And parathyroid level is normal, sir. CCT chest and abdomen is normal. And
HIV?
Sir, thyroid is sir, HIV is negative, sir.
HIV is negative.
Sir, Vidal is negative, sir. And should we suspect Vidal, sir, here? Should we that Vidal is important, sir?
Why?
Sir, TB is sorry.
VDRL. VDRL.
Sir, that can present like this is sir. Neurosyphilis can present like this, sir.
Bulbar.
Sir, I'm asking, sir, like should we would sir?
Sensory, if you are considering a doctor, mainly David sir.
Sir. Okay, sir.
I think the phenotype is not very much.
Yeah.
And
MRI would have,
sir, MRI date
would have picked up some findings there possibly in a and tertiary syphilis, isn't it? So they would have had some cardiovascular findings. They would have got it. May not be isolated neurosyphilis alone.
And sir, EMG date we have taken, sir, and MRI spine with MRI spine with brain we have taken, sir.
Compressive has to be ruled out.
Yes, sir. Yes, sir.
And any other features of basically imaging, role of imaging in MND in this patient?
Sir, if it is a sir, that lateral tracts sclerosis we can see in the just to rule out other causes, sir. Basically, MRI should be taken. Like sir, frontotemporal dementia if it is there, and any CV junction anomaly, sir.
Yeah.
Sir.
Yeah.
CV junction anomaly or any and any compressive high cervical cord compression if it is there, and any cerebral atrophy and
usually
progressive supranuclear palsy and all if you suspect along with that.
Motor neuron disease, you can see atrophy of the motor cortex.
Yes, sir. Okay, sir.
And there may be thinning of the cord. Yeah, further other information.
Sir, EMG, we should get it done, sir.
Okay, so how would you diagnose clinically a case of motor neuron?
Sir, clinically, patient present with upper motor and both UMN and LMN symptoms, and any 3 of the 4, that is cervical, thoracic, lumbar, and sumbosacral, bulbar, cervical, thoracic, and lumbar. In any of the 3 out of 4 is involved, we can clinically diagnose motor neuron disease.
What is the criteria?
Sir?
Clinical criteria for diagnosis.
Sir, a particular
some
name of the criteria.
I don't know the name, sir.
LS Coriel criteria clinically to diagnose. And Any other, what is the other name of this ALS? Just for with not much.
Sir, the baseball player, New York baseball player, Leo. I am not able to get that. Leo Gardens. I'm not getting that
Lou
name,
Gehrig.
sir. Leo Gehrig.
Lou Gehrig.
Okay.
Lou Gehrig.
Lou Gehrig.
Who described ALS? Lou Gehrig is what it was called in American book.
Yes,
ALS is classically called as whose disease? One of the doyens of neurology. So many things named after him.
Yes, antibody.
Huh? Some joint, some neuropathy, so many things named after one person, no? Neurology.
Charcot.
Charcot. ALS was described by Charcot. It's his name that's there for that. Yeah, Lou Gehrig is what is it called based on the person who got involved. Okay. Can you name some variants of motor neuron disease?
Sir, based on their upper motor, UMN and LMN type, if it is both UMN and LMN,
okay,
it's amyotrophic lateral sclerosis, and if it is only upper motor UMN type, then it's progressive primary lateral sclerosis and pseudobulbar palsy, and only LMN type, we can have that flare limb syndrome and amyotrophic lateral sclerosis and
amyotrophic is mixed.
That is mixed.
SMA.
Spinomuscular atrophy.
SMA, isn't it? Spinomuscular atrophy.
SMN and
any specific type of SMA
Kennedy syndrome
seen in females?
Kennedy syndrome.
Kennedy's disease, isn't it?
Kennedy's disease.
Kennedy's disease, X-linked bulbospine. What is anything more characteristic of that disease? What is it associated with?
Sir, androgen insensitivity would be testicular atrophy.
Androgen, so they can have
gynecomastia and testicular atrophy. And usually it's seen in
this is one of the motor neuron disease where you can have sensory symptoms also, because bulbospino neuronopathy it is. So again, a common question they ask you, MND with sensory symptoms. That is, one is Kennedy's disease, and supposedly in elderly, if you get all the features of MND, but there are some sensory symptoms, what do you want to suspect?
Paraneoplastic.
Elderly patient, all features of MND is paraneoplastic. So these are the two situations possibly in an MND where you could have sensory. One in a young patient is Kennedy's, and in elderly it is usually paraneoplastic. What are the other variants?
Multifocal motor neuropathy with conduction clot. That is also
lower. DD.
And sir, hereditary.
You said monomelic, isn't it?
Yes, sir.
Monomelic.
Monomelic. Yes,
can you tell us something about the monomelic MNDs?
Sir, monomelic Hirayama disorder, usually that asymmetrical one limb is involved, sir. It's usually seen in males, and usually that bulbar involvement won't be there, sir. And
okay. So Hirayama's was described in Japan. In India,
sir, Madras. Okay.
Equivalent of Hirayama's. Madras is not the equivalent. Okay, tell about Madras. Madras motor neuron disease.
MND, that is usually in Madras they are described, sir. It's only seen in young patients, and progression is
males, females. Madras motor neuron disease. What's the sex predilection?
Both are
Madras
equal.
motor neuron disease is more common. No.
Females.
It's 5:1 females. Females. Young females. Slowly progressive. What is more characteristic, which you do not find in any other MND?
Family, hereditary.
Sensory neural, hearing loss. Bilateral, sensory neural, hearing loss. That's what you get it. Okay. Can you have hemiplegic variant?
Hemiplegic variant.
Does it have a name? Hemiplegic MND?
I'm not sure, sir.
Called as a Mills variant of MND. And then you have the monomelic type, which is described in North India. That was described by Dr. Chopra and his colleagues. So you have the Chopra's MND, isn't it? And then you have certain. Have you heard of something called as just involvement of the finger extensors. It could just involve one group of muscles that can get involved, not the entire things, not the entire limb. Not in monomilic, it is mono muscle. Finger extensor weakness associated with downbeat nystagmus. It's called as a few-dove syndrome. So motor neuron disease can be hemiplegic, it can be monomilic, it can be single muscle involvement also. These are rarer subtypes that you could get. As I think we discussed earlier, Parkinson's, isn't it? Parkinson's can be related. What is that variant called as?
FND, ALS plus syndrome, that FND plus ALS.
Yeah, it belongs to a island, group of island. It's named after that island. Yeah, it's Guam's motor neuron disease or ALS Parkinson's complex. So it's more common in those islands, Hong Kong related islands that are there. So these are rare variants possibly.
Raghu, just a last question.
Yes, any other questions or doubts?
The severe wasting and fasciculations we were telling like suggestive of anterior hornset. So why can't it occur in other like whether root involvement or radical or a nerve involvement?
Sir, fasciculation is basically because of the muscle contraction, sir, and that motor nerve involvement only because of the that whatever the conduction it's coming back to the neurojunction only. So if it is the sensory nerve involvement, whatever the neurotransmitter is coming, it's not coming to the muscle end only, sir. So we won't get fasciculation.
The thing is anterior hornset has a direct impact on the metabolism of the muscle actually.
Yes, sir.
If you take the muscle, you have muscle fibers type 1, type 2, type 2A, 2B.
Yes, sir.
So
yes, sir.
those are all determined by the anterior hornset. So
Okay, sir.
the proportion of the type 1 fibers of type 2 fibers. So overall, the metabolism of the muscle is determined by the anterior hornset.
Anterior.
So in case of anterior hornset failure, it is the failure of the metabolism of the nutrition to the muscle, so
Okay,
which leads to significant wasting.
Okay, sir.
Any other questions or queries?
Any other disease where you see specifically tongue fasciculations with this nasal twang of voice and nasal regurgitation of food? Is related to myasthenia gravis. Nothing but a myasthenia gravis. But what are the types of antibodies in myasthenia gravis?
Sir, bulbar myasthenia antibodies are anti-musk, acetylcholine receptor against antibodies. Sir. Anti-musk and
muscomyasthenia is the one which can have a tongue fasciculation, wasted tongue, and a bulbar dysfunction.
Okay.
So, in case of a patient, sometimes they will have bulbar onset MND. So, only he will present with bulbar symptoms, they will have tongue fasciculation, no other finding. So, there they should definitely rule out a muscomyasthenia, which is a very potentially treatable condition. So, if you get any UMN sign, it will completely take out the muscomyasthenia. And any other muscle disease or muscle disease which can mimic motor neuron disease?
Muscle disease, sir.
Especially metabolic muscle disease.
So, metabolic muscle disease, sir, like motor myopathy, sorry, mitochondrial myopathy, like.
So, motor neuron disease is nothing but wasting and exaggerated reflexes. So,
yes, sir.
In which metabolic myopathy is exaggerated.
Sir, hyperthyroid.
Systemic disease.
Thyrotoxicosis, okay, sir?
Yeah, hyperthyroidism and hyperparathyroidism.
Hyperparathyroidism, okay, sir.
And hyperparathyroidism, as the initials are stellic neck drop, so it is also one of the causes of neck drop, myasthenia, the polymyositis, hyperparathyroidism.
Yes.
So sometimes these can be really troubling you, hyperthyroidism, thyrotoxic myopathy, or hyperparathyroidism related myopathy. Sometimes you may not be able to differentiate immediately. they will be having the hyperreflexia, and planters in this patient you have not got. So in metabolic myopathy also planters will be mute or a flexor. So it is a very doubtful situation, ambiguous situation. So better to rule out all those entities. What is the mechanism of preserved abdominal reflex in the area?
Sir, mechanism of
action.
Sir?
Only what I remember is the degenerative conditions usually.
So long-standing degeneration, that's what has been traditionally taught. There's no specific mechanism as such. Why the superficial reflex is preserved in here. Degenerative disease, yeah, that's what it's.
Should we routinely check for a deep abdominal reflex in these kind of, there is ambiguity between a UMN with an LMN lesion like this? Would it help?
Deep abdominal reflex are also the same. They can be preserved.
Except for maybe spinal cord disease, I think abdominal reflexes in other conditions, spinal cord, it helps you to localize in certain ways. But otherwise, I think in all other conditions is plus minus there. But it has to be checked as a routine because in your case sheet it will be there. You present the case, and quite a few times undergraduates and all, they ask you to demonstrate that. So I think it has to be there. Any other questions, Balaji?
No, sir. I think there are no questions.
Fine. I think then we can conclude.
Yes, sir. Thank you so much, sir. It was a very useful discussion. I think it was comprehensively covered. I think most of the postgraduates, it will be very useful for all of us. In the absence of a lot of clinical cases and COVID taking the increasing rise in the number of cases. Thank you so much, sir. And thank you, Raghu, for presenting a wonderful case through which we all got to learn a lot. Thank you so much, sir. Good evening, everyone. And thank you, members, for the active participation. Good evening.
You, sir, and
Thank you.
for this opportunity. Thank you.
Thank you, sir. Archith sir and Sharath sir. Thank you so much.
Thank you.
Thank you so much.